Okay, so picture this. You've got this pile of notes. Maybe you're studying, maybe you're preparing for, a tricky situation at work. And, you have to get your head around these really important laws, the Mental Health Act and the Mental Capacity Act.
Yeah.
It's pretty dense stuff, isn't it?
It really can feel like trying to find your way through a maze, yeah. You've got the key documents, you've pulled out the main points, but how do you actually turn all that information into something you can use?
Exactly. And that's what we're trying to do today. You've shared your source material on the MHA and the MCA, and we're going to, well, dive deep into it. The aim here is to unpack the absolute must-knows, focusing on the high-yield stuff that helps you understand these acts, whether that's for, clinical practice, exam revision, or just feeling properly informed.
Mm-hmm. Think of us as sort of guides through your notes. I'll help pull out the key ideas and explain why they're important, the context.
And I'll make sure we hit all those essential points you've highlighted. We'll break it down logically, just like you would for revision. Sound good?
It sounds like a plan.
Okay, let's start then. First up, the Mental Health Act.
Right, the MHA. So looking at your sources, the Mental Health Act is essentially the legal framework you use when someone needs assessment or treatment for a mental disorder, but they aren't able or willing to consent to come into hospital voluntarily.
It gives the legal basis for detention, right? And for giving treatment, even if they don't agree.
Precisely. And you flagged a really important exclusion right at the beginning in your notes. It generally doesn't apply if someone's presentation is only because they're under the influence of alcohol or drugs.
Okay, that's a key distinction. Why is that?
Well, the MHA is specifically about mental disorder. Being intoxicated, while it definitely changes someone's mental state, isn't usually seen as a mental disorder under the Act itself, unless there's an underlying condition or maybe a dependency that needs MHA treatment.
Right, got it. Now, your notes lay out all these different sections of the Act. They're like the specific tools for different situations, yeah.
Yeah,
This is often where it gets a bit confusing, I think.
absolutely. But grouping them can help. Maybe think about purpose. Let's look at the sections used mainly for hospital assessment and treatment first.
Okay, so Section 2. Your sources say this is for assessment. It's for up to 28 days. And crucially, it can't be renewed.
That's right, non-renewable.
And the application usually comes from an AMHP-approved mental health professional or sometimes the nearest relative. And it needs 2 doctors' recommendations.
Yes, 2 doctors, and one of them has to be Section 12 approved, meaning they've got specific expertise in MHA assessments.
And Section 2 allows for treatment during that time, even against someone's wishes.
It does, yeah. If it's necessary for their health, their safety, or, to protect other people, it gives the team time to properly assess.
Okay. Then, building on that, if assessment under Section 2 shows they need longer-term compulsory treatment, you might move to Section 3. Your notes say this one is for treatment.
Correct. Section 3 is for treatment. Initially, it's for up to 6 months, but this one can be renewed.
Right. And again, it involves an AMHP and 2 doctors. But the timing is different here, isn't it? Your notes say both doctors need to have seen the patient within 24 hours for a Section 3.
Yes, that's a key difference. It reflects the need for a really current assessment before you commit to longer-term detention and treatment. And that renewal process for Section 3 is also really important. It forces a regular review to check if detention is still needed.
Okay. What about emergencies? Your notes mention Section 4. That's an emergency assessment order, 72 hours.
Exactly. You use it when waiting for a full intent. Section 2 assessment would cause an unacceptable delay. It can be initiated by a GP plus an AMHP or nearest relative.
And often it gets converted to a Section 2 once the person arrives at a hospital or place of safety.
That's typically what happens, yes. Section 4 is really just a rapid way to get someone to safety for that proper assessment. It's very short term.
Okay. Now, what if someone's already in hospital voluntarily, but then they try to leave, and the team's worried? Your notes cover holding powers inside the hospital, Section 5-2.
Yes, Section 5, subsection 2. That allows a doctor, the one in charge of the patient's care, or their nominated deputy to detain a voluntary inpatient for up to 72 hours.
And that gives time to sort out a proper MHA assessment, like a Section 2.
Precisely. It buys that crucial time if the team thinks the person meets the criteria for detention and isn't safe to just walk out.
And then there's Section 5-4. That's a shorter holding power, just 6 hours, and it's for nurses.
That's right. It lets a suitably qualified nurse stop a voluntary patient from leaving the ward for up to 6 hours. Again, it's about immediate safety and giving time for a doctor to come and assess, potentially use 5-2, or arrange the MHA assessment, recognizes the nurse's role right there on the ground.
Makes sense. Okay, shifting focus now, outside the hospital walls. Your notes mention Section 17A, supervised community treatment, or CTO. What's the idea here?
CTOs, community treatment orders, they allow patients who've been under certain MHA sections, like Section 3, to be discharged back into the community, but they remain formally under section.
So it helps manage risk after discharge.
Yeah, that's the main goal. The key power is recall. If the patient doesn't stick to the conditions of their CTO, like taking meds or attending appointments, and that increases their risk, they can be recalled to hospital for treatment.
Okay. And finally, the police powers you noted. Section 135 requires a court order.
Yes. Section 135 allows police, with a warrant from a magistrate, to enter private property using force if needed to remove someone thought to have a mental disorder and take them to a place of safety for assessment.
So that's for when concerns arise about someone behind closed doors.
Exactly. When access is needed for an assessment and can't be gained otherwise, the warrant provides that legal authority.
And Section 136, that's for public places.
Correct. If police find someone in a public place who seems to have a mental disorder and needs immediate care or control, Section 136 allows them to take that person to a place of safety. Your source mentions this detention can last up to 24 hours while an MHA assessment is arranged.
So again, a temporary measure to get someone safe and assessed.
Precisely. The place of safety could be an A&E or ideally a dedicated mental health suite.
That's a really clear run-through of those MHA sections. And thinking about them grouped by function, hospital, holding, community, police definitely seems like a good way to revise them. Makes the numbers less abstract.
It does help, I think. Understanding the why and when for each section is key, not just the number itself.
Okay, let's completely shift gears now. Let's look at the other big piece of legislation in your notes. The Mental Capacity Act, MCA 2005.
Right, the MCA. It's a totally different beast, although sometimes, they do interact. The MCA is a statutory framework designed to empower and protect people aged 16 and over who can't make specific decisions for themselves.
Just as if some impairment of their mind or brain.
Exactly. It clarifies how decisions should be made for them and who should make them.
So it's much broader than the MHA. The MHA is specifically about mental disorder and compulsory treatment.
Whereas the MCA applies whenever someone lacks capacity to make any kind of decision. That could be due to dementia, a learning disability, brain injury, delirium, even severe mental illness if that illness impacts their ability to make that particular decision.
Right. And it's interesting, your sources mentioned reviews of the Act found that while the law itself is okay, in practice, well, there have been negative experiences. Decisions haven't always followed the principles.
Yeah, and awareness seems limited sometimes, which really underlines why getting to grips with this is so important. If it's not applied correctly, people's rights can just, go out the window.
So getting it right is crucial. And the foundation, according to your notes, is these 5 core principles.
Yeah.
They're non-negotiable.
Yeah, solely fundamental. Everything else flows from them.
Let's quickly list them. First, presumption of capacity. Always assume someone has capacity unless proven otherwise.
Yep, start there. Don't jump to conclusions based on age, diagnosis, appearance, whatever. The onus is on proving lack of capacity. Second, support to make own decisions. You have to give all practical help before deciding someone can't make the decision.
This is so important. It means actively trying, using simple language, pictures, translators involving family, choosing the right time, anything reasonable. You only assess capacity after you've tried to support them.
Third, right to make unwise decisions. Just because a decision seems unwise to us doesn't mean the person lacks capacity to make it.
This one can be tough in practice, can't it? People with capacity are allowed to make decisions others disagree with, even risky ones.
Yeah, I could see that. Fourth, best interests. Anything done for someone without capacity must be in their best interests.
This is the guiding star once you've established lack of capacity. It's about what's best for them, specifically, not what's easiest for everyone else.
And fifth, least restrictive intervention. Anything done should restrict the person's rights and freedom as little as possible.
Absolutely. Find the minimum necessary interference to achieve what's needed in their best interests. So those 5. Presume, support, unwise, best interests, least restrictive. PSUBL maybe. Remembering those is vital because they underpin everything in the MCA, don't they?
They really do. They're the ethical and legal core.
Okay, so how do you actually assess capacity? Your notes lay out a test, and you stressed it's decision-specific and time-specific.
Absolutely critical points. Capacity isn't a blanket thing. It's about this particular decision right now. Someone might have capacity for deciding what to wear, but not complex finances, and capacity can fluctuate, like with delirium.
And like you said, it's not based on the diagnosis itself or age or how someone looks or behaves. The test itself has two stages, right? Stage one, is there an impairment of or disturbance in the functioning of the mind or brain?
Yes, that's the diagnostic bit. Is there something affecting their brain function? Dementia, stroke, learning disability, acute confusion, severe depression.
And stage two, does that impairment or disturbance mean the person is unable to make this specific decision at this time?
This is the functional part. The impairment has to be the reason they can't make the decision. And to be able to make it, your sources say they need to do four things.
Okay, what are they? First, understand the relevant information.
Yep. Understand the pros, cons, alternatives.
Second, retain that information long enough to make the choice.
Mm-hmm. Even if just for a short period.
Third, use or weigh the information as part of deciding.
So actually process it, consider the consequences.
And fourth, communicate their decision.
Okay.
By any means talking, sign language, blinking.
Exactly. Understand, retain, use, weigh, communicate. If the impairment means they can't do any one of those four for that specific decision, then they lack capacity for it. You really need to remember those four. That's the core of the functional test.
Got it. Understand, retain, use, weigh, communicate. That's the checklist.
Pretty much, yeah?
So if someone lacks capacity for a decision, the best interest principle kicks in. And your notes mention a checklist in the act itself for working out best interests.
Yes, decision makers must work through these factors. It's not optional. You have to involve the person as much as possible. You have to consider their past and present wishes, feelings, beliefs, values.
And you have to consult others, right? Carers, family.
Yeah.
Your notes say they have a right to be consulted.
They do, yes. Anyone involved in their care or interested in their welfare. You also mustn't make assumptions based on age or appearance. And you need to think, might they regain capacity later? If so, could the decision wait?
Following that checklist seems crucial to making sure the decision is genuinely person-centered.
It is. It's the safeguard against just doing what seems convenient.
Okay. Your notes also mention Section 5 of the MCA Acts in connection with care or treatment. What's that about?
Section 5. It basically provides legal protection for carers and professionals when they're doing necessary day-to-day care for someone who lacks capacity. Things like helping wash or dress, giving medication, managing small amounts of money.
Things that would normally need consent.
Exactly. Section 5 offers a defense against claims like battery or theft, but only if the carer reasonably believed the person lacked capacity and that the act was in their best interests. And crucially, the MCA principles have to be followed. Your source also mentions the new criminal offense of ill treatment or neglect under the MCA, which adds more weight.
Okay. What about restraint? That's covered under Section 6, you noted.
Yes, Section 6 deals with restraint. It defines it quite broadly, using force or threatening it if the person resists, or restricting their liberty of movement whether they resist or not.
And when is it allowed?
Only if the carer reasonably believes it's necessary to prevent harm to the person who lacks capacity, and the amount or type of restraint used is proportionate to how likely and how serious that harm is.
Proportionate, that's key. And your sources highlight something really important here. Section 5 protection does not cover acts that deprive someone of their liberty.
A vital distinction. Brief, proportionate restraint to prevent immediate harm might fall under Section 6 and be covered by Section 5 defense. But ongoing restrictions, like locking doors to stop someone leaving, or constant supervision meaning they're not free to leave, that's likely a deprivation of liberty.
Which needs separate authorization.
Exactly. Which brings us nicely onto some of the other MCA tools and safeguards for more complex situations, future planning, and yes, deprivation of liberty. Let's start with advanced care planning.
Right, advanced care planning. Your notes say this replaced advanced directives.
Yeah, it allows someone aged 18 plus AF while they have capacity to make decisions about future health care in case they lose capacity later.
And the key point from your notes seems to be the difference between wishes and refusals. Wishes for treatment are considered, but not legally binding.
But a valid, applicable refusal of treatment is legally binding.
Even if it seems not in their best interest at the time.
Correct. A valid advance refusal overrides the best interests principle for that specific treatment. And for refusals of life-sustaining treatment, there are extra rules must be written, signed, witnessed, and state clearly it applies, even if life is at risk.
And your source notes, they can become invalid if the person changes their mind with capacity, or if, say, an LPA covers the same decision.
Right. And ignoring a valid refusal is serious, Your notes mention potential claims like battery or assault. It really shows the power of exams decisions.
Okay. What about planning who makes decisions for you? Lasting powers of attorney, LPAs.
LPAs, yes. Someone 18 or over with capacity can appoint one or more attorneys to make decisions for them if they lose capacity later. Two types. One for property and financial affairs.
And one for health and welfare.
Exactly. But they only become active if the person loses capacity and the LPA has been registered with the Office of the Public Guardian.
Registration is key then, so it's a way to choose your decision maker in advance.
It is a very important planning tool.
Okay, next up in your notes, the Independent Mental Capacity Advocate, or IMCA. Who are they?
IMCAs are independent professionals.
Right.
Their role is to support and represent people who lack capacity to make certain major decisions and who don't have any appropriate family or friends to speak up for them. They ensure the person's voice is heard.
And your notes are specific about when they must be involved for someone lacking capacity with no one else suitable to consult. That includes decisions about serious medical treatment.
Yes, serious medical treatment. Also, hospital stays planned for longer than 28 days, or changes in accommodation like moving to a care home planned for longer than 8 weeks.
So specific triggers for mandatory involvement if there's no one else.
Right. And there are other times they can be involved, like care reviews or safeguarding cases, and times they're not needed, like emergencies, or if the person already has good support. That list of when they are and aren't needed is really practical.
What about research? Can people who lack capacity be involved in research? Your notes cover this.
Yes, but under very strict conditions. An ethics committee has to approve it. They check it's safe, related to the person's condition, couldn't be done as well with people who do have capacity, and the benefit outweighs the risk. Or it's minimal risk research for new knowledge.
And consultation is needed. And they must be withdrawn if they show resistance.
Absolutely. Consultation with carers or a nominated person is vital. And yes, any sign of objection from the person themselves means they must be withdrawn immediately. It's all about protecting them while allowing vital research to happen.
Okay. Then there are court-appointed deputies. Your notes say this replaced the old receivership system via the Court of Protection.
That's right. If someone lacks capacity for ongoing decisions and hasn't made an LPA, the Court of Protection can appoint a deputy, they can manage finances, make welfare decisions. But interestingly, your notes point out they cannot refuse consent to life-sustaining treatment for the person.
Right. And the Court of Protection itself, that's the overarching body.
Yes. It has jurisdiction over the whole MCA. It's the final arbiter on capacity disputes, best interest decisions in complex cases, and it appoints the deputies. And the public guardian supervises deputies and attorneys.
Okay, last big topic under the MCA in your notes, and it sounds complex. Deprivation of liberty safeguards. DOLS.
Yeah.
You know these are an amendment to the MCA.
Yeah, DOLS came about because of court rulings. Essentially, it provides the legal framework and safeguards for depriving someone of their liberty if they're 18 or over in a hospital or care home, lack capacity to consent to being there and the arrangements, and that deprivation is considered necessary and in their best interests. Crucially, this applies when they're not detained under the Mental Health Act.
So it fills a gap for people restricted in care settings who aren't under the MHA.
Exactly. It's about ensuring those restrictions, which amount to a deprivation of liberty, have proper legal authorization and independent checks.
And the process involves the hospital or care home applying to a supervisory body, like the local authority, or maybe the ICB now, for authorization.
Yes, that's the mechanism. They have to apply for authorization. An unauthorized deprivation of liberty isn't lawful under the MCA unless it's specifically ordered by the Court of Protection.
And your notes mention doctors needing specific training for DOLS assessments, and that it's often not seen as core GP work needing payment agreements. Sounds like it has real practical implications.
It's definitely a complex area, both legally and practically. The authorization process involves independent assessments to ensure the criteria are met and the person's rights are protected.
Wow, okay. We've covered a huge amount there, pulling from your detailed notes. The MHA, with its sections for compulsory detention and treatment for mental disorder, and then the much broader MCA, covering decision-making capacity for any impairment, focusing on those 5 principles, the assessment test, best interest, and all those tools like advanced decisions, LPAs, IMCAs, and DOLS.
Yeah, bringing it together. MHA is primarily about detention and compulsory treatment for mental disorder. MCA is about empowering and protecting people who lack capacity for any reason, focusing on support, best interests, least restriction. They're distinct, but they can overlap or interact, which needs careful handling. For instance, DOLS applies because someone isn't under the MHA.
Right. To really make this stick,
Mm-hmm.
maybe try thinking through a scenario. What if you had, say, an older patient with dementia who's refusing treatment for a serious infection? First step would be the MCA, wouldn't it? Assess capacity using those 4 points.
Yeah.
Understand, retain, weigh, communicate.
Absolutely. Start with MCA capacity assessment for that specific decision about infection treatment. Presume capacity, support them, use the test.
And if they lacked capacity for that decision, then you'd move to a best interest decision involving family, considering their wishes.
Exactly. Now, if that same patient was also, say, severely depressed and actively suicidal due to that depression, then the MHA might become relevant for assessing and treating the mental disorder, potentially leading to detention if needed.
So you might be using both acts for different aspects of their care.
You might, yeah. It shows how you need to apply the right framework to the right issue. Thinking through examples like that really helps connect the dots.
And maybe a final thought to chew on. How do these acts really balance things? Protecting vulnerable people versus upholding their rights and autonomy, even when their ability to decide is impaired.
That's the constant tightrope walk in practice, isn't it? It's a huge ethical and legal challenge that healthcare professionals face every day. There aren't always easy answers.
No, definitely not. Well, that brings us to the end of this deep dive into your source material on the Mental Health Act and Mental Capacity Act. Thank you for walking us through all that important information.
My pleasure. Getting these acts right is just so fundamental to good ethical care.
Absolutely. And if you listening are using notes like these for revision or just want to test yourself on topics like this, you might find resources like passthemsra.com and freemsra.com really useful for more practice questions and study materials.
Yeah, definitely worth checking out if you're prepping for exams or just want to solidify this kind of knowledge.
Okay, until our next deep dive then, keep exploring these important subjects.